Let me talk about the implications for treatment. Obviously, with a diagnosis of complex PTSD, a trauma-informed approach is the most appropriate for this client. We also know that she had not done well in treatments that were not trauma-informed, so that also implies a trauma-informed treatment approach. I always want to take into account what has worked and what has not worked in previous treatment. In the trauma field, we have been influenced very profoundly by Judith Herman's phase-oriented trauma treatment model. Her reworking of a trauma treatment phase-oriented approach first proposed by Pierre Janet at the end of the century. Phase 1 in this model, before we address the trauma, the first stage of the work is a stabilization, helping individuals to overcome the autonomic dysregulation, the attacks on their body, the suicidality, the addictive behavior, establishment of a safe environment, because we can't recover from trauma if we are still in an unsafe environment, and the establishment of emotional and autonomic stability, the ability to tolerate and regulate emotion. Because how can individuals address traumatic material if they can't tolerate day-to-day stress? The second phase of treatment was focused on traumatic memory. And what we have come to define as traumatic memory has changed over the course of years. At one time, we thought, back in the 90s, we thought that treating traumatic memory meant retrieving all of the memories in all of their details. And as the field matured, we came to realize that remembering was not the same as recovering. And that the important thing about this phase is coming to terms with the past, whether it's coming to terms with the events or coming to terms with the implicit memories. And then the final phase, Judith Herman called the phase of integration and meaning making, coming to terms with who we are as a result of the trauma, helping individuals to find meaning in their life choices, whether raising children in a nonviolent way, pursuing a social cause or a career focused in some way on justice or healing. Now, there are many, many treatments for trauma, ranging from psychodynamic and psychoanalytic treatment, supportive psychotherapies, EMDR, eye movement desensitization and reprocessing, which was developed in the mid-'80s and became popular beginning in the 90s. Internal family systems, which has again first was described in 1995, has recently become extremely popular. And then somatic approaches to trauma, very, very important in the light of Bessel van der Kolk's book and mantra that the body keeps the score. So we have many treatments to choose from. Some are evidence-based. EMDR is evidence-based. It was developed by an experimental psychologist, so its effectiveness is well tested. Prolonged exposure has a very good evidence base, but because the evidence base rests on research with subjects who did not include any trauma survivor with an addictive disorder, with self-harm or suicidality, dissociative symptoms, a history of hospitalization, psychotic symptoms. It is not been tested on complex post-traumatic stress. If the research is based on subjects with simple PTSD and none of these exceptions. There is an evidence base for IFS, but it's a study of the use of IFS with rheumatoid arthritis patients. And then somatic experiencing has two randomized controlled studies. And so it has an evidence base if that's important to you. Because we also have treatments that are more popular with our clients. And when we're deciding what treatment to use, we have to think about, is this a treatment that my client will complete? Will this treatment speak to my client? So I could easily rule out many treatments because there's a very high dropout with prolonged exposure because of its intensity. Also, prolonged exposure works on one memory at a time. And so for clients with complex PTSD, often they have endured hundreds of traumatic events. And so for them, prolonged exposure is not a good choice. Supportive psychotherapy had been tried. Psychodynamic trauma-focused therapy had been tried. The EMDR had dramatically exacerbated her symptoms. She also had not done well with internal family systems. I wasn't sure if that had to do with the fit with the therapist. But what I also know is that internal family systems requires more affect tolerance than my client had. And she was so intellectual that a somatic approach, aspects of somatic approaches were helpful for her, but a purely somatic treatment would not have been a treatment she could tolerate.